All right, thank you, Tim. Good morning, and it's morning here in Pittsburgh too. It's only 11 o'clock. So I'm happy to be with you today, and thanks for signing on. We are going to talk a little bit about why the GP should purchase a CBCT machine and how we use it to boost our bottom line. Like Tim said, I'm in private practice here in Pittsburgh. And I'm a fee-for-service practice, and I'm AACD accredited. So my practice is sort of focused on cosmetics, and I've been narrowing my focus for the last 20 years. So I think that now, particularly with the pandemic and the so many people not having the uncertainty of not knowing what's going on forward, I think cosmetics are really going to dry up in the next couple of months. I was around back in 2008 and the same thing happened then. Prior to that, cosmetics were just flowing. I was doing veneers left and right. There was no amount of money I could say to people that would stop them from doing the treatment. I'd say, your treatment is $10,000. They'd be like, okay. Your treatment is 15, let's do it. Your treatment's 20, sure. Everybody could get financing. And then the recession happened in 2008 and it all came to a screeching halt. A friend of mine described it as someone turning off the faucet. And that's exactly what happened. So we had to kind of switch our gears a little bit in the practice, and I started focusing more on need-based dentistry, and there was still a lot of dentistry, cosmetics going on for younger people, and we'll talk about that in a minute or two. But the good news is that, of course, dentistry survived, and it not only survived, it thrived, and I'm certain that the same thing is going to happen now, and I see lots of signs pointing to that, and we'll talk about those in a few minutes too. I usually start this lecture by talking about how, as general dentists, in order to really thrive, we have to separate ourselves from the other dentists, right? We're in very challenging situations as far as practices go. There's corporate dentistry that we compete with. There's diminishing insurance returns. And there's lots of dentists out there. And in order to be one of the practices that are growing and succeeding and making the kind of income and having the lifestyle that we want, we sort of have to separate ourselves from the others and to practice in the way we want to too. And for me, that is practicing seeing fewer people, but doing more production. So I have what we call slow dentistry in our office. We see maybe 3 or 4 patients a day in my chair and maybe 5 in the hygiene chair, but we're doing longer procedures and we're doing more procedures in the same sitting. And because of all of the new regulations that we're going to see and all of the new ways that we're supposed to practice. Sorry, you can hear my dog barking in the background. I think we're all gonna maybe have to move in that direction a little bit, but I can tell you from my experience, it's been an amazing transition for my practice and for me. This is the ADA Return to Work Guideline Toolkit for all of us getting back to practice after the COVID situation. And you see how long it is, right? We're gonna be making lots of changes. I think that the basis of the change is we're going to be protecting ourselves and protecting our patients. And in order to do that, we're going to be seeing fewer patients during the day, and we're going to be spending more money out of our pockets to see those patients. So all of our staff is now have to be protected with PPE. We are going to have to install safety checks and equipment to take care of aerosols. And we're not going to want to turn over our rooms like we once did. And we're not going to really be able to turn over our rooms like we once did. So the traditional model of restorative dentistry that might look something like this for us, where we're working on multiple chairs and we've got hygienists seeing patients every 45 minutes, probably is not going to be the case anymore. That we're probably looking at doing longer procedures for every patient, and our schedules may look more like this, where we've got staggering and that we've got breaks in between every patient. I know in our office now we're looking at having a half an hour between each patient in each room. So we'll do a procedure, sterilize the room, and then let our air purifiers run for that half an hour after we've done the procedure to try to minimize the microbial load in the air in each of these operatories. And fortunately, I work in closed rooms, so that makes it a little bit easier for us, so we can go from one room to the next, and I'll stagger it that way. Hygiene-wise, same situation. Each of our hygienists will spend an hour with their patient, and then that particular room is going to have to sit fallow, if you will, for a half an hour. So we're going to be seeing more quadrant dentistry, longer appointments with more procedures in each one. And we're going to return, I think, to a little bit more need-based procedures for a while. And who knows, I think there may be some attrition in our staffs. We may have to cut our staffs back a little bit. And we ourselves may even have to work some longer hours or some weekends. But we're well positioned for that. I think dentistry is really well positioned to move forward to do that. And I think it'll be better for us. I know it's been better for me, that we will be able to use our technology to not just do better dentistry, but to do more, if you will, efficient dentistry, and to diagnose better. So it's better for our patients and it's better for us. And there's lots of technology out there today, and we're all exposed to so much of it. And we have to decide what to buy and when to buy it and how that's going to benefit us in the long run. And I think we have to look at each piece of equipment and sort of think, where does this fall into my bottom line? So, you know, there are caries indicators, there's cameras that fluoresce, that do interproximal caries detection. Of course, we have intraoral scanners, and we have our CBCT machines that we're going to talk about today, moving from 2D dentistry to 3D dentistry. I work with digital smile design a lot. I work with my intraoral scanners to do clear aligner therapy. But I have to say, I think the most important leap for me is when I moved from 2D radiographs into 3D when I got my machine. So comprehensively examining somebody. For a lot of us, new patient exams and recall exams are very fast situations. For a lot of us, comprehensive exams have in the past involved our hygienist seeing the patient first, possibly doing some x-rays, whether we've popped in the room or not to examine them. Sometimes that's based on what x-rays they report they have taken in the past, and some of us have set protocols for what x-rays we take on every new patient. Previous to us getting the CBCT machine, I would schedule an hour for our comprehensive exam for a new patient. I would have them fill out all their forms. I'd get the bullet from my patient care coordinator or my hygienist, and then I'd pop in, meet them for just a minute or two, and then I'd order whatever films I felt necessary. Oftentimes it was an FMX, sometimes a pan, and bite wings. And now, then the hygienist would take those. I would come in and do my exam based on that material, and then oftentimes would clean them at the same appointment. And there are many things we can do to really elevate that comprehensive exam. And when we do that, we're not only finding that the patient needs more dentistry or possibly a different kind of dentistry, we're also showing the patient something different than they've ever seen. So when patients come in and go through our now current comprehensive exam, they're wowed by the technology. I can't tell you how many times they're saying, I've never seen anything like this before. It is people feel like you are far and away above your fellow dentists, and they are quick to refer to you. So, and we often ask them when they say to us, wow, this is like nothing I've seen before. My hygienist will say, well, please send your friends and relatives, would love to take care of them. So not only do we want to acknowledge what they're saying, but we want to just go ahead and take that extra step, ask them to refer people. So many of us have switched to digital x-rays, of course. We have decreased radiation and they're, enhanced images. We can run them through our software programs on our dental software and get better diagnosis from them. We use fluorescence in our office to detect caries. So we've got that camera and it detects pit and fissure caries, and my hygienist will run that over every patient as well. Transillumination to see interproximally. So we actually take less bite wings than we used to. Every single patient in our office, when they enter our office for their new patient exam, is scanned digitally. And that allows us to chart from the digital exam. I can chart all existing restorations, and it's also a great tool to show people what their condition is. So they're sitting up and looking at your screen as opposed to trying to hold a mirror and show somebody, oh, you've got a cracked tooth back here. And the most important thing I think that we're doing on virtually every patient now is taking an initial cone beam on them. And that gives us so much more information than we would have had in traditional x-rays. So new patient exam, the patient comes in, I'm doing the same situation. They're meeting everyone in the office. They're coming back and they're kind of getting a little tour of our office. We sort of hit the technology as we come back. That's our CBCT machine. That's our intraoral scanners. That's our digital mill that we can do same-day dentistry on. And then we take them back into the operatory, and my hygienist or patient care coordinator, we use them interchangeably. They both do this. Sits down with the patient kind of knee to knee and says, so tell me a little bit about what's going on with you or your teeth. And we just kind of let the patient talk, and then they ask them if they can take a few photographs. We always take a few photographs. And then they might do a quick exam just to get a feel for the condition of their mouth. Periodontally, restoratively, occlusally, from a malocclusion standpoint and from a disease standpoint. And then they'll come kind of give me the bullet, and I come in and meet with them just for a few minutes. And then we take our CT, our CT scan, and then we do our digital intraoral scan. Some spot probing at that time as well. And this just takes a couple of minutes to scan through the mouth. And I think this is one of the most important aspects for case acceptance, this coupled with the CT images. So you see, as soon as you bring that up, the patient is completely engaged. They're trying to touch the screen. It allows you to flip it around everywhere to see everything. And then we set them up and we have the screen with the CT images on it and with the intraoral scan on it. And together, those two pieces of information are really, really powerful. And patients can really understand it. I think that the CT machine, the CT diagrams are a little technical for some patients, but if you are able to pair that with the intraoral scan, they really understand it, and it helps them move forward with a lot of treatment. So we go through this process with every patient, and we're looking at these CT scans very thoroughly on every patient to try to get the comprehensive diagnosis for them. So I want to start with kind of an easy situation that we all have in our practices every day, and just talk about how this machine has made a difference for us and helped us not just manage our patients, but produce more in our offices. So a typical patient calls for a limited emergency exam. This particular one is a 57-year-old woman who says that she had had a root canal in her tooth, and she's a patient of mine, a long-standing patient of mine, had a root canal in her mouth, and she had been getting a little swelling next to that root canal for probably 3 to 4 months, on and off, and called up and wondered if I could prescribe some antibiotics for her. We all get these patients, right? So instead of prescribing over the phone, we asked her to come in, and what would happen in a typical exam like that? So the patient would come in, we've scheduled half an hour for her for a limited exam. We're taking PAs in the area that's affected. When she comes in, we do a quick my hygienist or assistant would do a quick look. Yes, she's got swelling on the lower right, doctor, and would take a couple of PAs, one PA or possibly two PAs. Then I'm going to percuss the area and, just try to assess it. And when I see this situation, right, she's got a crown on tooth number 31. She has an all ceramic crown on tooth number 30 with a big core and an endo done by an endodontist. And that's a relatively new one for her. That was about 2 years ago. She had that done. And then she's got a big composite on tooth number 29. And it looks like there might be a little bit of decay under that composite, right? But I don't know if your x-ray techs or assistants and hygienists are like mine, but sometimes they miss the apexes of the roots, right? So I can't see number 29 on either of those x-rays. I see number 30 clearly on both of them. And on the top one, I can kind of see number 31, the apexes. Let's do this. See the apex number 31 a little bit, right? So what would typically happen in a situation like this, we would say to this patient, well, it looks like something's going on with this root canal tooth that you had done about 2 years ago. I see a little translucency around it. I think something might be going on with that. So I'm going to send you back to the endodontist and have him have a look at that. That's what I would have done maybe 18 months ago. Just send her off to the endodontist. And what happens then? She's been 3 to 4 months kind of like nursing this along, coming and going, and I say, go to the endodontist. And she says, Doc, can't you give me an antibiotic for that? So maybe I would or would not have prescribed her an antibiotic, and I would have referred her back to her endodontist. She could, one, take the antibiotic and it goes away again, and she's going to sit on this another 6 months or more. 2, she could think, I'm going to go to the endodontist, no antibiotic, I'm going to go to the endodontist, and like by the end of the week, it isn't flared as much, and she kind of forgets about it, work gets busy, not go into the office, not calling the endodontist. Third option, she could call the endodontist, make an appointment and go and hear what he has to say about this. And it could be a number of things. He could want to retreat. He could take a CT in his office and find a root fracture. He could look at the other teeth in the area and need endo in the other area, all sorts of possibilities. Or he could just look at this one and say, I think there's a root fracture and we're probably going to have that tooth out. So what does the patient do with this situation? We all know what the patients do, right? They either immediately call you up because they're afraid, or you don't hear from them for a year. They just kind of go away. Or you don't see them again until it's time to clean their teeth. And if they're good every 6 months, that's great. You'll see them again soon. But if they're not, you may not see them for a little while. They may just kind of like disappear into the wind. And unless your front desk or your patient care managers are really on top of things, where they're really following each and every patient up and they're able to get them on the phone, then we may not see this patient for a while again. Certainly, we may not get them back to us, back to, if it is an extraction situation, and then back to whoever's going to extract and put an implant in. That may take a little bit of time, and their patients are kind of out there in the wind. So alternatively, if we're able to do the CT in our office, which is what we do now, we will go ahead and shoot the CT, right? And then we're going to evaluate this. And I know when I first got this machine, I was a little daunted by trying to evaluate every CT, and I was afraid I was going to miss things, and I also really didn't know how to navigate through the software. It's really pretty easy to navigate through, and once you use it a little while, I think you'll see that you can't live without it. So this is the images that first comes up, and you see 4 squares. And the first thing we do is line up. If you look up here in the upper right, we're going to line up the crosshairs on the tooth that we're interested in. And then if we look on the lower right, upper left, lower right, we see that these teeth are now in view, the area that we're looking at. And if we get closer to that, we double click and we open that screen, we can see that tooth number, it's tooth number 31, that has the ceramic crown, the big core, and the endo, previous endo. Looks like it has a big lesion around it, right? Both roots involved in the lesion all the way up to the furcation. But what else can we see on this CT, we can see that tooth number 31 that has a crown on it also looks like it has a periapical lucency, right? And if we look at these through different cuts, on tooth number 31, it also looks like something's going on in the furcation of that tooth. Like perhaps the lucency is all the way up to the furcation. And we can view it the other way through the other cut, and we see tooth number 31 looks like it's got a lucency between both of the roots and all the way to the buccal. I think we've got one more here. And as we go further down, or further down, we can see that that lucency on tooth number 31 is all the way between the roots. And it looks like we might have a root fracture in tooth number 30. And we get further down into tooth number 30, and we see that is a huge lucency involving both roots. So this gives us an opportunity to diagnose the patient fully while they're in our chair. So that was the CT views, and each of these you can also see with the PanRx view, right? So people are always asking, well, what do you charge them for that? How much are you charging a patient that comes in for a limited exam? Are you going to charge them $350 for the CT? Are they going to then need another CT if you refer them out? What's the situation there? So we're a fee-for-service practice, so I'm charging them for the limited oral exam, and we charge them the fee for a PanRx exam for this. And we bill this to their insurance post-billing in our office. We fill out their insurance forms for them, and we code this as a PAN because there is indeed a PAN that comes with it. So it makes it somewhat reasonable for the patients. We're still getting paid for our work, but I'm not charging them $325 or $250 each time we shoot a CT. We're shooting lots of CTs, and we're billing them out at the regular fee we would for a PAN or for a PanRx X-ray. Okay. So let's just talk about what would happen with this patient then. So I have decided that tooth number 30 has a root fracture, and instead of sending that patient to the endodontist, I know that I want to talk to that patient about removing that tooth and having a site preservation done and then having an implant placed. Tooth number 31, I believe, needs an endo, so I'm going to refer her out to the endodontist to have a look at tooth number 31. What we treatment plan in our office then is for exactly that. I'm going to treatment plan her for the restoration of tooth number 30 with an implant, and I'm going to treatment plan her for, in this case, a new core crown on tooth number 31 because it is an old crown on that tooth. And I'm going to then refer her to the periodontist to have tooth number 30 removed and have an implant placed. And I'm going to refer her to the endodontist to have tooth number 31 treated. Before she leaves our office, she knows what our fees are to complete the whole treatment. We've actually taken a deposit on those fees. We've called the endodontist and scheduled her for tooth number 31 evaluation and treatment. And I've called the periodontist and scheduled her for the removal of tooth number 30 and the subsequent implant placement. In doing that, we become the quarterback of the treatment. We are the ones that are directing all the treatment. We know exactly when she'll be in each place, and then we're able to have her scheduled back in our office. She's made a deposit, and that sort of psychologically locks her into the treatment, and she understands the whole situation. So instead of just sending this patient out on her own, sort of undirected to the endodontist, maybe she'll go, maybe she won't, maybe we'll see her again. Instead, we have the, something in the neighborhood of, $7,000 to $8,000 worth of treatment in our office, diagnosed, payment deposited and scheduled into the future, and we've got her going on the track she needs to go on to get there. So I, at this point, I don't personally do any implants, and I don't do any endo. So people were always asking me, why would you buy that cone beam machine when you don't do either of those things? For me, it's all about being in charge of the entire comprehensive diagnosing. Let's take a peek.
Tonight, I want to come clean. Seriously, I want to come clean. I don't have a lot of vices, okay? I don't drink. I don't jewel. I don't go to hookah lounges. I know I look like I do, but I don't. But I am an addict. And I am addicted to Amazon, which I know doesn't sound crazy as far as addictions go. Amazon Prime was my first taste of the white horse, but then I leveled up to the hard shit, which is Prime Now. Does anyone here have Prime Now? Okay, you know what I'm talking about. For $119 a year, you click on what you want, and within 2 hours, a sweaty Ukrainian man shows up at your door with toothpicks, diapers, 3 bell peppers, and a Yoda costume for your dog. How do you say no to that? Convenience is the commodity that matters most to our generation. I can't believe I used to physically go to stores, take money out of my pocket and pay for stuff like a peasant. With Amazon, I just do this. And things come to me like I'm an emperor.
Convenience. It is the commodity most valued by millennials and the younger generation. So, how does that affect us? And what does that have to do with the CT machine? Well, moving forward, I know we talked about cosmetics a little bit at the beginning and how we're not going to be seeing elective procedures maybe for a while. But back in 2008 when that happened, and I think the exact same thing is happening now, as we come out of this this social distancing, as we come out of the quarantine, I think that our more mature patients are going to be conservative. They are going to be more need-based. But our younger patients are still looking to move forward, just like they did in 2008. They still want their cosmetics. They're driven by social media culture. Record numbers of younger patients are seeking out cosmetic dentistry, and they're seeking out plastic surgery. And over the last 5-6 weeks, I have found that that hasn't slowed down a bit. In fact, it's ramped up a little bit. So convenience and immediate response. So over the last few weeks, we're still getting requests for smile consults. We were still getting people asking us to schedule them to, especially now that they weren't working or weren't committed to going to the office, they had free time. They wanted to come into our office and get their smile consults and move forward. They were all younger people, I can tell you that. But we decided to try to do some virtual consultations via Zoom. And it has turned out to be so much more successful than I anticipated. Virtually every patient that wanted to come to our office that had been scheduled out, we offered them a Zoom consult earlier. We only charged them $50 for it, but it was about a half an hour long via Zoom. And I found that they were so much more relaxed, Zooming to me about their concerns inside their own homes. And we were able to do a lot of diagnosing and then move them forward in treatment. So here, bottom left, this is my patient care coordinator. She's talking to the patient via Zoom, kind of doing the same thing we do in the office. Tell us a little bit about what's going on. Up here, I've got a mom and a son talking to me together on Zoom, and here's me just evaluating a little bit. So let's take a look at this case. I met this girl 2 weeks ago, maybe 3 weeks ago via Zoom conference, and we just had her come while we were in the office for another emergency. We had her pop in and had a CT taken, and we were able to move forward with treatment. And I think this is the biggest thing for patients. This is a 23-year-old girl, 24 maybe, who asked for a consultation in the office because she didn't like the way her front tooth looked. She had a crown done, I think, 7 or 8 years ago on tooth number 9. This tooth is not endoed, I believe she said. Although I'm not certain. We'll look at the CT in a minute. But she told me that she wanted to straighten her teeth out a little bit, wanted to get rid of her gumminess a little bit, wanted to have whiter teeth, and didn't like the way this one tooth looked. And oh no, this tooth was root canal. So she had a fracture in this tooth before, fell, had a endodontics done, had a crown placed. That crown didn't look great, had it replaced, and the replacement crown had fallen out multiple times over the last 2 years-ish. And late last year, her and her fiance went on a cross-country road trip, and the tooth fell out multiple times on their road trip. So she actually had it re-cemented. I thought this was a fun story. Had it re-cemented in 5 states as they crossed the country. So I think this one will be a fun one to write about. But we zoomed we zoomed with her. She's in her house. I was in one part of my office, and my patient care coordinator was in the other. Sometimes we do this from home. We asked her to just kind of get close to the Zoom camera and to take, just get close, and we hit screenshots and screenshotted her so we could talk to her a little bit about this. So after the Zoom conversation with her, we decided that she told me that this tooth is constantly throbbing. You see she's got a lot of inflammation. I think we got a closer picture. She's a lot of inflammation above tooth number 9, and that she really likes a natural look, and she wanted to fix that discrepancy in size between her 2 central incisors, but she wasn't really interested in veneering a lot of stuff. So I talked to her about doing some clear aligner therapy to straighten out her little bit of malocclusion, some gingival sculpting or crown elongation on the front teeth, and some whitening. And then what were we going to do about this tooth number 9? And to me, this looked like this might be an extraction implant situation just because of all the inflammation there already, maybe some decay going on. Symptomatically, it's throbbing from time to time, and it's fallen out so many times, right? So this is a tooth that has a very long history, and I'm already thinking I'm going to remove this tooth and have an implant placed. But if she comes to my office and I take a PA of that, and it's not indicative of what, it's not absolutely indicated that needs to be, like, that I can see a root fracture on there, then I'm in the same situation. Well, let's send you off to the periodontist and have him have a look, or to the endodontist and see if they can take a CT scan and maybe decide whether or not that's retreatable. And these millennials don't want to go to many different offices. They want a plan, they want it, and they want it now. It's pretty simple. So she did pop into the office, and we took a CT scan, and we were able to take some better photos on her. And you see just how inflamed she is above tooth number 9. And she does have some discrepancy in her size between 8 and 9. So definitive treatment plan for this girl was based on what was really going on with tooth number 9. So same situation. I've got the CT in the office. We take that CT scan. I'm evaluating all of her teeth, but I also want to, of course, focus on the single tooth that we're looking at. So let's get a little closer to that. We first align on the lower left side. Each time we're aligning the occlusal plane we want to look at. Then I'm going to align on the tooth, and you see it brings it into view down here. I'm going to double click on this box, and then I could get a really good look at this tooth, and I can go through the cuts and see if I do see a root fracture. And what I see on this tooth is that there is decay under this crown, and lots of it. And I think there's a possible fracture up near the crown of this tooth. And I'm looking at it the other way, and you can see all the decay up there as well. Otherwise, she's in great shape, really healthy mouth. So this one lets me definitively diagnose her and definitively get her going on treatment. So that day, you see the decay there a little bit more. That day, I can definitively give her the diagnosis, and we did. We treatment planned her for about $12,000 worth of treatment. She signed a treatment plan, signed all her consents. I did a digital intraoral scan because I want to plan this implant with my periodontist. I want to do a fully guided situation with my periodontist. So I have my digital scan, I have my CT scan, and I send them to a company that marries them together. And we'll do that on the next case. And that allows me to put that implant exactly where I want it to go, so it's restoratively driven. I know where I want this case to end up, and there's no kind of sending her off to another office. When these younger patients decide they want to have treatment done, or they want to do it, they're immediately calling me up. So I believe that the Zoom consult really helps with that, that we're able to talk to them within a day. Boom. Even I'm going to continue to do this even after we are back open and fully running. We're going to try to Zoom them within a day to at least build that relationship, get that rapport, give them an idea of what we're thinking of. The next appointment is then going to be records, which will be the CT scan, the digital scan, our photographs, and locking down the treatment plan. So in this case, we are going to remove this tooth, have a fully guided implant placed in there. I'm going to immediately provisionalize that. I'm then going to, after healing, we're going to do some limited cosmetic orthodontics to straighten the other teeth up. We're going to do some gingival sculpting. We'll do some whitening, and then we'll restore that tooth permanently. So I'm not sure, we may do the orthodontics first and then take the tooth out. We'll see just how fractured it is, see how much it could tolerate. But that allows me to do the entire comprehensive plan and get her to commit to it at the beginning, so she knows the entire thing. If I send her off to an endodontist or a periodontist, who knows when I'm going to see her again. My periodontist sometimes cannot see patients for 8 weeks. And by then they are on to something else. They no longer want to have their teeth done. Now they decided they want to have a new car. They want to go on a trip when they're able to go on trips again. So we sort of really have to strike while the iron is hot.
Are millennials spoiled babies?
Do millennials stink?
Millennials have it too easy.
Millennials are the absolute cheapest.
Now, 5% strip.
They are ruining Halloween.
The thin-skinned generation.
Millennials.
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 Blame it on the millennials.
So, convenience, it's the most important commodity for the millennials, the Gen Xers, the Gen Zers, and we have to respond to that because I believe that they are the ones that are going to be doing most of the dentistry in the immediate future, most of the kind of dentistry that we want to do. And they are also the ones that are driving the total future of our practices. If we're going to really thrive, we've got to respond to them and we've got to meet their needs. We've got to recognize their desires and meet their needs. And their needs are do it now, do it here, and do it fast. This is a 17, 18-year-old patient who is missing 3 teeth. He is missing 5, 6, and 7. His number 6 was impacted, and he had some surgery done to get it available for brackets for orthodontics. And when that happened, I don't know what happened because this was before my time, but it ended up where he had bone loss on the teeth on either side, and not only lost 6, but he lost 5 and 7 as well. So a little bit of a difficult situation for him, but he is finished with his ortho, and you see he's still in a bit of a class 3, so he's a difficult bite, but he needs implants to restore this area. And how do we treat a patient like this? What is the best case scenario for this, and how do we manage this as the quarterback? So I have him in my office, and you see, right, he doesn't clean his teeth very well, but this is because it's not because this guy doesn't want to, it's because he's embarrassed of this space. He doesn't wear anything on it. He's tried flippers, he's tried Essex appliances unsuccessfully, says he just can't wear them. And so he goes without teeth. And because of that, he is very conscious of his look. And I think it's hard for him to look at his own teeth and brush them psychologically, not physically, right? So, we try to be just really sensitive to the impact that dentistry and smiles have on younger people, because it's really huge and it really works on their self-esteem. So we take a look. He's already had some bone grafting in this area to replace all the bone that he's lost. So he's ready for implants in this area. You see he's got pretty decent teeth otherwise. But how do we as the general dentist move forward with a case like this? We want to be in charge. We want to be the quarterback. So I'm going to take all of his photos, and you see his bite, And then I'm going to do the things that we do on every patient, but particularly important for this patient is that we're going to take a CT of him and we're going to take a digital scan of him. And then we're going to marry those two things together. So I want this to be a completely restorative driven case, meaning I want to place those implants where it's best for the crowns to be placed. And because we all know what happens if we don't tell the periodontist or the surgeon or whoever's placing our implants for us, if it's not us, and sometimes even if it is us, we want those implants to go in a very specific position in order to make it work restoratively. And if they are put in a position that's best for bone, when we're looking at it clinically, that is not necessarily the best restorative position. And if we take the information from the CT scan and from our digital scan and merge those, we can develop a plan that has the restorative in the position we want it, and then we retrorally figure out where those implants should go, and it's based on the available bone. So this is a company I use, 360 Imaging, and I send them, I upload the CT scan, we upload the digital scan to them, and then I get on the phone with them, and this can happen anywhere. You know, we're doing it via Zoom conference, similar to this, anywhere we are. So it's me, whoever's placing the implants, and the design company together. And we're working to idealize this patient's outcome. So we know that we want to put 3 implants in there, and we start looking at where is the available bone for the implants. You know, of course, we're looking at the distance between them, the depth of the implant, the size of the implant, and we're getting an idea of the brand that we're working with. And we start looking at not just the Panorex, but we're looking at the CT scans. And we are evaluating what position works best for that in each of those implants separately. And looking at it through all the different views, and I'm talking this through with not just the surgeon that's placing them, but with the design team that's looking at this from a prosthodontic standpoint as well. So we have decided where we want the restorative, and this is kind of my part of it. I'm telling them where I want these crowns to be, how I want this to end up in the bite, and what I want them to look like. And then we are merging that with the CT information as to the brand of implant, where the bone is available, and where those implants need to be for the hardware to work properly for me to put the restorative where I want it to be. So we know we want these access holes, and I always like to do screw retained if I can. So we're working at trying to make this screw retained and making it work everywhere. And we have, this is tooth number 7, and we know where it's supposed to be restoratively. We know that I can have a channel through the cingulum to put this, make this a screw retained. I have my Nobel implant placed. And you see that superimposed on top of the bone. And you see this little, on the facial here of the implant, there's a little bit of a void in the bone. And we know that at surgical time, we want to place a little bit of extra bone there. So as a guide to the surgeon as well, he now knows, because we're all on this call together, that we're going to put these implants, and he's agreed to it, and also has a lot of input into what he believes is the best situation for the implants. And we decide, yeah, we're going to put a little bone grafting in there as well. So we've got them all lined up. We know where the soft tissue is. We know where the opposing teeth are. We know where we want this to be from a restorative standpoint. We look at it through all the views. Tooth number 5. It's going to be nice and sunken bone. It looks very good. And from that, this design company, from this phone call, which takes us maybe 10 minutes, you know, it's not a long time, but it's such an important phone call, they will then fabricate a surgical guide for us, which looks like this. So this is a surgical guide, and it's on a lucite model. So it's sitting on a model, and it has a guide pin in it right now. We've got the surgical kit all set up. And this goes off to my periodontist. So I'm in my periodontist's office now taking the photographs of this. He had in his schedule set aside 2.5 hours for this procedure. It actually took him about total time start to finish about 46 minutes. We timed it because it is so predictable and so easy with this guide. So he's doing a little anesthesia. We're flapping open the tissue, getting the site ready. Here is the surgical guide in place. So we're pushing it in place with an instrument. When we tried it on the first time, it was hard to get on. So I had to just relieve it with an acrylic burr a little bit around the back teeth, and then it slid right on. So here's the surgical guide in place. And then we put the actual gauges in. And then we're just going to, one at a time, place the implants. So we're going to do the surgical drill. Pretty bloodless, pretty easy situation. Drilling each one, and then he's placing the implants in there. So all the holes have been drilled right through that stent. We're confident because of the CT scan that we are exactly where we want to be, sunk in bone 100%. Then the implants come out. We're going to put the implants in, just torque them, put them into place. Healing caps, suture them up. And my guy loves to suture. Suture them, totally shut everywhere. And then there's the Panorex taken. That's with the straight up Panorex in his office. So we have a little bit of distortion in that. But, here is the Panorex on top is the planned Panorex. This is where we intended to put them based on our CT scan and our digital scan. And so that's the design, and that's the actual input. And if it weren't distorted, you'd see they're really right on. They're exactly on where they want to be, where we want them to be. And this patient is now healing, ready for his restorative. When it's time for the restorative, we're simply going to take a punch, and I'll do this in my office. He doesn't even need to go back to the periodontist. I will punch those 3 spots, and I'll know right where they are because I still have the surgical stent. So I'll put the surgical stent back on his teeth. I'll take a denture marker that has, the little matchsticks markers that have the blue tips on them. I will just go right through the surgical stent and mark the 3 places where those implants are. I'll use a punch, a single punch through each of those places, and then I can unscrew the healing caps, or not the healing caps, I'll unscrew the surgical screws that are covering the implant access then, and I will put in impression posts, scannable posts, and I'll scan those, and I'll send those right off to the digital lab and have them fabricate those teeth that we've already designed digitally with the 360 design before. So it's a really simple procedure for the next step. It makes it really easy on me, 100% predictable, and really easy on the patient. When we started this, back when he came to my office that first day, I already knew that we wanted to put 3 implants in there. We diagnosed him for that day. We charged him for the surgical stent, and I think those stents cost about the whole, maybe somewhere between $275 and $475, depending on how many teeth are involved. So we incorporate that into the fee, the surgical stent. But that first day at his diagnosis, we give him the entire treatment plan, the fee for everything, on our side of things. So I give him the fee for the surgical stent and the design, for the restoration of those 3 implants, and for any provisionalization along the way. So before he leaves my office that day, before we fabricate that stent and I have that phone call, he's already made a deposit, and we always ask for half of the fee that day. And if they pay the full fee that day, we give them a discount. We give them a 3% discount or a 5% discount. If they're paying us by check, it's 5%. If they pay us on a credit card, it's 3%. If they want to pay us in full that day. So they're already locked into treatment, and we have not only a good cash flow from that, we're able to give them the best possible dentistry. So the CT machine. We can use them for endo. We can use them for implants. We can use them for sleep. We can use them for diagnosis of lesions. But the most important thing that I use it for is diagnosing comprehensively and directing treatment. It has been a huge boon for my practice. So I told you at the beginning that I don't do any implants, I don't do any endo. Since I've had this machine about 1.5 years, and I comprehensively have been diagnosing with it about that long length of time. Back in November-ish, I hired a dentist to come in and do the implants in my office because I wanted to make it even easier. And because we're diagnosing so many implants and we're able to keep our cash flow in such a good position, I decided to hire someone to come and do the implants in our office. So that's been working out really well for us. And almost every implant we do that has any kind of cosmetic application, anything other than a single tooth, like a posterior single tooth, like that number 30 we talked about at the beginning, we're doing that restoratively driven. We're really doing most of our things fully guided these days. And in January, I hired an endodontist to come twice a month to our office and do the endo. Because of this machine, we're diagnosing so much endo that it's made perfect sense for us to do that. So this machine that has not only like helped me keep work in my office through comprehensively diagnosing and keeping things moving like that, it's now allowed us to do to have other specialists come in the office and do work too. So I think this is what's going to happen in our future. Since the quarantine, you know, here in Pennsylvania and I guess everywhere else, we are only allowed to see emergency patients. But our endodontist has been working through the entire time because that's pretty much all he's been seeing is emergency patients. So he's worked at least a day, sometimes 2 a week over the last few weeks, doing lots of endo. And it's only been possible because we have that machine in the office. I know and I'm confident we're going to be doing a lot of dentistry in the future. And I think we're going to come out of this stronger than we did before. And people that are positioned, dentists that are positioned to keep it in their office to comprehensively diagnose are going to see that this is just going to continue to grow and grow. Some contact information if you have any questions for me, if you want to contact me or talk to me about any of the other things we talked about today. I'm happy to answer any questions now if you've got any. Tim, are you still with me?
I am. So a doctor asked, does the periodontist have the same CBCT you are using, or is this an issue? And which company are you using to design implant placement for surgical stent? Those are the two questions right now.
Okay, let's start with the first one. So that is a good question about the specialist. So if we take the CT scan in our office, do the specialists want to take another one? No, we simply burn the CT scan for them. I send it on the disc with the patient if we're sending them out somewhere. And we can also talk to them via upload with the design companies. And we use a company called 360 Imaging to design our surgical stents. But I also work with prosthodontists sometimes to design these stents, and we're looking at getting a 3D printer in the office to print our own.
Okay, and then next question. They said you talk a lot about CBCT, but which company are you using?
Oh, this is the PreXion machine.
Okay.
Yeah, and this machine has done great for me. You know, when you look at what kind of machine to buy there's you know, not just limited to the CT machines, but pretty much any piece of equipment you invest in. You know, this is a big investment. I think I always go through this process where we're looking at, I'm looking at several things. I'm looking at referrals from people that are using that machine. I'm looking at the cost of the machine. I'm looking at the service. I'm looking at the training I can get. And with a CT machine, you need some training to start with, right? You just can't put this in your office and kind of take off. There's a little bit of a learning curve, and the more you use it, the better you get at it. But I purchased the PreXion machine because of the diagnostic quality. And I had several friends that were using it, and they told me the service was incredible, and I have the same experience with them. And the training has been really good for me. It took me from zero knowledge of CT reading to being able to use it on a daily basis. And Tim, you may know Oliver, but my guy Oliver has been just incredible. I can call him at any time, and he can walk me through anything I need, and he's really helped me become much better at it. And they also have a couple other people that are really teaching how to read these machines well, like Dr. Julian and VJ, their radiologist, has done something really helped me bring it along. But we also have to look at the value. So there are, the pricing of these machines is pretty, there's a pretty wide range of pricing in there. And this particular machine that I have, I felt was a great value. It also had value and it also had quality. So I was able to get the diagnosing quality that I expected and wanted, and at a price that was reasonable for my practice.
Next question is, well, first of all, Oliver is awesome. He's on the East Coast. The good thing with PreXion is we have 7 Olivers across the whole entire country.
I've met a few of them. But
yeah, so if anyone has an issue or question or needs additional training, there's 7 of us throughout the United States. Next question is, can CT take place of conventional digital bite wings to diagnose caries?
Good question for that. I still take bite wings in my office. What the CT can do, especially, you can get an idea if there's gross caries on it, but if there's small incipient caries, I think it's important you still take bite wings. I take far fewer bite wings than I used to, for 2 reasons. I use the CT machine for some of them, and I also have a transillumination camera that I use. So I am trying to take the minimum amount of radiation we can for our patients, and they appreciate that, of course. But we also have to maintain diagnostic quality. So if I were to take, normally in the past, we used to have a protocol. I worked with a doctor that took bite wings every year, no matter what. Most of my patients, we might take bite wings every 2 to 3 years now, depending on their caries level. But it's not going to completely take the place of that. Same thing periodontally. You can get a really good idea with a CT read of horizontal bone loss, of vertical bone loss, but you simply still have to go in and do a periodontal exam. You still have to do probing depths on every tooth, but you don't need to take an FMX for that. You can read that with the CT imaging.
Which classes did you take to feel comfortable with interpreting the images?
Tim, I might leave that one to you. You could probably tell them there's some great classes you can take. We had training in the office, right? Because when you get this machine, they come to your office and train you to do it. And then I also took some training with VJ and what's his last name?
Parashar?
Yeah, who's amazing. And most of that's been online, simply online.
Yeah, Dr. Vijay Parashar, a radiologist out of Phoenix, works at the college out there. He also runs a company called CBCT Readers. You guys can look them up online. It's just cbctreaders.com. And what we suggest is when you get your machine, you send the first few to him, and runs around $85. You can pass that on to the patient. And I know a lot of our doctors will take those reports and give them to the patients. It's about 4 or 5 pages with pictures and shows them, everything in the slide. So it's a good way for a doctor to learn. And PreXion can actually pay for the first 3 of them, 2 to 3 scans for you. But as far as training goes, we have courses throughout the whole country that we use Catapult primarily because they all have our machine, every single one of them. They all have our images. They love the machine. They speak about the machine and show the doctors how they're using it. So yeah, training is really not an issue. Feeling comfortable with the machine, not an issue. We're always there to help our doctors. So I always like to say the work doesn't start for us until after you buy the machine. So we're there whenever you need us. Question
Let me just add to that for a second, Tim.
Sure.
I just want to say that, so there are services like reader services. So if you have a patient that you have a suspected lesion on and you are not sure about it, especially early in the beginning, you can simply upload your scan and send it off to a server, and it costs like $75 to $100. And there's a number of them, but VJ does a great one. And they will read that radiograph for you. So you will get a report back with a differential diagnosis, and then you'll know where to go from there. So if you don't feel comfortable, and I don't feel comfortable diagnosing most obscure lesions that you see, like you might take you have a patient that you've taken a PA on, you see something funny, then you take the CT scan, and then you're like, I don't know what this is. You can send it to the reader and you'll get a differential diagnosis from an oral radiologist. So it not only gives you confidence, it helps your patient, right? So it lets you know what you want to do. You do not have to send every scan to a $75 reader. In fact, I only send maybe one scan a month out now to be read, something that I'm not sure what it is. And that comes with experience and with training. So, and like I said, I had zero experience when I bought this machine, hadn't used it at all, and now I use it every single day. And most of what you hear from anyone that has a CT machine will say it's just a great investment because the return is incredible. You do so much more dentistry because you're able to diagnose more dentistry, so it's better for you and better for your patients. Okay, sorry, Tim.
No, thank you.
I'll get off my soapbox.
No. Do patients accept to pay for CT fee for comprehensive exam only? What is the best approach for this?
Yes. So I've had, like we talked about a little bit earlier, I typically will charge them a Panorex fee for that. If I have a patient, occasionally I'll get a patient that's referred to me from somebody else that I'll get a patient that's referred from another dentist or a periodontist, or the endodontist will send somebody to me, and they're coming in not as a comprehensive exam, but more of a consultation, then I will charge them a full fee for it. We'll charge them $250 for the CT scan. Most other patients that are in our office as routine patients, we're charging them our Panorex fee, which is I think about $150, I'm going to say, something in that neighborhood. And I'm not getting any blowback about that at all. People are paying for it.
Perfect. Got another question regarding acceptance. It says they currently have a 2D pano and treatment acceptance is low. What is your acceptance rate with CBCT?
So I had a 2-year-old Panorex machine that I sold. I think I got $8,000 for it, which is not a whole lot, and then upgraded to this CBCT machine, which I paid for. So I was still paying on my Panorex machine and got the CT machine, which most people are like, oh, why would you do that? That seems like a bad use of resources. But it has been, like I told you, I now have a periodontist in my office that's placing implants, and I have an endodontist in every other week doing endo. And now I'm only working 3 days a week because of that, which is kind of nice for me, and I'm only doing what I want. And it's also allowed me to have a general dentist associate in there that's doing all the general dentistry. So it's been good for me. But speaking to case acceptance, a few things will make a difference. Like, I think the number one thing is that you have so much more information, and it gives you more confidence to present things to patients. When you're able to say, here on your CT scan, I see this. I see you have a fracture in this root. I see that you have adequate bone to place an implant here. I see it gives you that confidence to move forward with treatment plans at that present time in your office. So if you're taking Panorex x-rays, it's some information, but there's still that sort of like, I'm going to send this off to the specialist to have them take a look at it. I'm sure many of us were like this, and I was too. I would think, this is a great patient. Here's a patient that's missing a tooth. This is a great case for an implant. I'm going to talk to them about an implant. Hey, anyone ever talked to you about putting an implant in that area? And they say, yeah, some my last doctor did, but he wasn't sure there was enough bone. And yeah, I don't know. I'm fine without it. It seems like it's doing okay. Nothing's really going on. Like I've missing that tooth for 10 years. And then you're like, okay, well, let's take a Panorex. It looks like you might have enough bone, but when you have a machine like this in your office, you can say, well, I'd like to take a CT scan, which is a much higher diagnostic quality than the other kind of x-rays you've probably had in the past. And that's going to allow me to see exactly the amount of bone you have and exactly the site that we could put this implant in. And it's going to let me look at all the teeth around it as well. And so you take that and then you're able to say right then and there, well, either you have adequate bone, I can see here, but you can see how this bone compared to the bone of the tooth behind it has shrunk over time. There's still adequate bone here now, and I think it's important that we place an implant here so it doesn't continue to atrophy your arch, and so your teeth around it don't continue to do more work than they should. This is an important one for you to have, and here's the exact fee that it's going to cost to do it. And now I have it done in the office, but I would say before, and I can send you to my periodontist who's going to put this implant in for me, and here's how this will go. He's going to put it in this day. You're going to heal for 3 months. You're going to come back on here. Today is May. You're going to come back here in August on the 15th, and I'm going to unscrew it, and I'm going to take an impression. And 2 weeks later, you're going to have a tooth in that. It frames it all out for them. And I find that when you have all that information, you're more confident, and it allows the patient to make decisions better than sort of the vagueness that we had before. Because if you're saying, I'm going to send you the periodontist to see if that's okay, people can't make a decision on kind of like, is that going to be okay or not? I'll wait and see. It's been 10 years. Who needs to do anything now?
Thank you.
You're welcome.
Next question is, does PreXion software enable one to translate CT to FMX?
I'm not exactly sure what we mean by that question.
You know what, Dr.
You can have that one.
Dr. Khanna, I'm going to take you off of mute and have you ask the question directly. Is that, hopefully that's fine? Dr. Khanna, are you still there?
Yeah. Can you hear me?
Yeah, we can hear you great.
Oh, great. Okay. Yeah, I was at one of the, I think it was the Yankee Dental Convention, and I was, I forgot what the company was, but he had taken the CBCT and then he had converted that image into an FMX series. Just like we had in school.
Yeah. I have never done that. You can't, it does automatically have a Panorex there for you to look at. And you can do it into like a bite wing-like image, right, Tim?
Yes, you can.
And I'm not sure about like if you could put it into a mount that would look like an FMX. Is that possible?
Yeah, that's what they had. Yeah, like a mount. Yeah.
I'll have to, Dr. Khanna, I'll have to get back to you on that because
Okay,
that I don't know.
Okay, no problem.
Yeah,
Yeah.
I don't know either. Sorry. I told Tim not to ask me any questions I don't know the answers to.
Yeah, thanks for stumping us like that.
Yeah.
Thank you. Yeah.
Sure.
The next question is, I think you kind of answered this already, but when you went to decide to take the step from 2D to 3D, what was most important to you? Was it the service? Was it the image quality? Is it just a referral from a friend?
I think there were three things that were important to me. The price was important, of course. It had to be the image quality that it had to be the image quality. And Tim, you could probably speak to that a little bit more than I can as far as cuts go in comparison to other machines. But this PreXion machine has excellent image quality, and it's at a very value price. So it's like there are two great things together. And I had many friends that were using this machine successfully. And I had many friends that were using other machines they weren't thrilled with, that had issues with service, that had issues with training. And this was kind of the trifecta for me. And it's borne out. And that's why, that's why I'm comfortable talking about this machine, because I use it every day. And I've been exposed to other machines. And there are other great machines out there, don't get me wrong. There are other machines that are doing a great job, that are training a great job. But this had all the three things for me that were important.
So this question I love, and I'll take this one. It says, how do we get the PreXion? So this is a good one. Thank you. If everyone has chat, or I'll just write it down. If you go to www.prexion.com, there's a place where you can request a demo of our software. There's also, under support tab, there's a bunch of videos that show off our software, and they're sort of training on how to position a patient, how to take a 5x5 on up to a 15x13, and how to do different things within our software. So thank you for that question. That was a slow pitch on a tee. I loved it. So I don't think
right, so PreXion is its own company, and so versus so you're direct to dentists, right? Or do you go through distribution as well?
We only sell through distribution.
Oh, I'm
Well,
completely.
the PreXion employees like Oliver, myself, Krista, Steven, the list goes on. We work for PreXion. We are the software specialists. We do the demos. We do the site visits to make sure the machine fits. But the distributors are the ones that quote the price and get the doctors financed.
And I financed my machine.
Yeah. Well, guys, at this time with the coronavirus pandemic, epidemic, whatever you want to call it, the financing companies are going nuts right now. Lowering rates, you can get up to a 10-year. I know that one of our distributors, you guys can call me directly. They're offering 10 years. The first year you don't pay anything. And the interest rate is nuts. And this question didn't come up, but I'm going to just address it, is what's our warranty? We talk a lot about customer service. Our warranty is 10 years, guys, on all parts. So we stand behind our machine for 10 years. You match that up with a 10-year loan, you have no worries at all for 10 years. So again, if you guys, if you want to write down my number, I can get you in touch with the distributor. I can set you up with your local PreXion rep, and they can do a remote demo for you, or if the country finally opens up, they can go in your office and do a demo right there in front of you. So I'll write my phone number in the chat, as well as saying it out loud. So it's area code 714-287-7330. So that's my direct line. That's my cell number. It's also on your screen in the chat. So if you want to know any more information about that, or just take the next step and look at our software in more detail, give me a call. Does anyone have any more questions for us? Well, I would like to personally thank Dr. McMahon. I think she did an amazing job. First time I've heard her speak. For me, she goes all over the country and speaks, and I will be following her closely. So
thank you, Tim.
That is all we have. If there's no more questions, I appreciate you guys spending an early morning with me here on the West Coast. And I will be sending a follow-up email to you guys. So if you put your correct email when you registered, you will get a link to another seminar we have today at 1 o'clock, as well as the video of this presentation from Dr. Susan McMahon.
Who's speaking at 1 o'clock today, Tim?
I believe it is Sam Hallibo.
Oh, my good friend. You'll like him, so tune in if you can. Thank you all. I really appreciate you spending some time with me, and feel free to contact me if you have any questions, and I hope to see you out there. Stay well.